Welcome back to the new norm. I'm Dr. Lou Graham, and this program is brought to you by Midway Dental and Catapult Education. Today's guest is, I think we're going to cover some hot subjects. Today's guest could be the most, I would say, this guy's presented to more dentists in the country than I think even a dentist has spoken. He's not even a dentist. He is a board certified pharmacologist. And in fact, a board certified, I should say, pharmacist. He is a dear friend, and his name is Tom Viola. So many of you have already heard him, either via webinars or the podium. And he is the founder of Pharmacology Declassified. And he really is kind of the go-to specialist, really dealing with pharmacology today. And as I am a geriatric dentist and I look at the lists and lists of medications, it is just unbelievably hard to keep up. There's just no doubt about it. So I think we're gonna hit some really, really cool subjects today. I want to just touch on two quick things. Tom's gonna be featured on two, what I would call Q3, Q4, or fall series programs. The first will be on Troubleshooting Tuesdays, where we have a great lineup on Midway Education. And Tom is really going to be talking on September 15th about local anesthetics. We'll touch on it today, but I'm telling you, it'll be so well worth a Tuesday evening 1-hour course, CE credit, of course. Then we're also doing virtual Fridays with Midway Education, and Tom will be a co-speaker in that course, and I will read it to you. He will be talking about the role of medical histories and pharmacology in oral diagnosis and treatment planning. So I think both courses you're just gonna get a whirlwind of Tom, and I'm hoping next year we launch a subscription type platform really based on the medical history and its role really in the dental patient. I think there's so much in the medical history that we just don't know. But let's get right down to it. I want to do snippets, and the first topic I want to talk about really with Tom is local anesthetics. So first off, Tom, welcome to the program.
Lou, thank you so much, and thank you to Catapult and Midway for having me be a part of this. I really appreciate it very much.
Yeah, you're our newest member to Catapult. It's an honor to have you and Miles, who've joined this year in COVID era. We love having you. You've just been a great new asset to our organization. So
Thank you.
Let's cut right to the choice, Tom. Septicaine. Let's talk about some of the myths about Septicaine, because I'm a huge user. I would love to hear what you got. Let's go myth busting on Septicaine. Hit it.
Absolutely, absolutely. So the first greatest myth about Septicaine is the fact that since Septicaine is so fat soluble, people often want to know, why is it so fat soluble? Why does it penetrate tissue so well? Why does it seem to reach parts of the tissue that other anesthetics simply can't reach? And again, it's because of that fat solubility. But then, of course, the next question is, why is it so fat soluble? And I say, well, that's because its ring structure is different. It has a sulfur atom in the ring, and that makes it much more fat soluble, and that makes it much more easy to penetrate tissue. But when I say that word sulfur, especially with my Brooklyn accent, it sounds like I'm saying sulfa. And people say, oh, wait a minute, so you can't give Septicaine to somebody who has a sulfa allergy? And I say, no, it's two different things. Sulfur atom and sulfa as in sulfonamide. So to be clear, you can have a sulfa allergy and still use Septicaine safely. However, there is the issue with sulfites. So to make it a little more complex, sulfites are what we use to preserve all local anesthetic cartridges that are containing epinephrine. So since Septicaine is only available with epinephrine, therefore it's only available with sulfites. And if you have a sulfite allergy, then you can't use Septicaine. So bottom line is, you can use Septicaine in patients with sulfa allergy, but not with sulfite allergy. Make sense?
It does. But Tom, let me ask you, are sulfites used in red wine as a preservative? Am I off on that one?
Not at all. So if my patients often say to me, so how do I know if I have a sulfite allergy? And I usually tell them, go home tonight, eat dinner at the buffet. Any buffet you like, because most buffets have sulfites in their food to keep the food looking pretty. Then stop off on the way home, pick up some beef jerky, because if anything is going to keep beef stable at room temperature on a convenience store shelf for 5 years without refrigeration, it's a sulfite. And then when you get home, 3 glasses of red wine. If I see you tomorrow, you don't have a sulfite allergy. If I don't see you tomorrow, rest in peace. And so that's how we work it.
Okay, so we've defined the allergies of Septicaine and its clinical use. Let me ask you, in your course on a Tuesday night, do you talk about, I don't want to talk about it now, I'm just doing the promotion. Do you talk about Septicaine and mandibular blocks, the issue or the myth? Do you talk about that at all on that Tuesday night?
I do, as a matter of fact. I will give you just some quick snippets. How about that, Lou? So I have a...
Okay.
I just want to say, I have friends of mine who are attorneys who keep that article laminated in their briefcase about how Septicaine can cause paresthesia and mandibular blocks. But to be fair, I've got an argument that will convince some people that it's not as scary as we thought.
Okay. Now, let's talk about myths about Lidocaine. Can we touch on Lidocaine, or is that
sure can.
not what you want to talk about? Great. Let's talk about myths about Lidocaine.
Yep. So the greatest myth about lidocaine is that you can only use lidocaine plain in a patient who is pregnant, because lidocaine is category B, and that's considered to be safer. If you looked at the FDA pregnancy categories, they go like school grades, A, B, C, D, and X being self-explanatory. So, lidocaine is category B, so that's safer than the other anesthetic agents we usually use commonly, Septicaine, Bupivacaine, and Mepivacaine, because they're all category C. Well, as it turns out, that is a bit of a myth on the part of lidocaine, because while lidocaine is indeed category B, it is no longer available plain. It's only available with epinephrine, either the 1 to 50,000 or the 1 to 100,000 dilution. So even though lidocaine is category B, it may not be perfect in every pregnancy, because some women who have had problems with eclampsia or preeclampsia can't use epinephrine. Epinephrine is a contraindication. So it turns out lidocaine may not be perfect for pregnancy.
So then,
of course, I get the next.
Openly, right. So wait a second. So then, openly, then you would go to Mepivacaine without the epinephrine, or am I off on that?
No, you'd be right. A lot of people go with Mepivacaine because it's epinephrine free, but actually, or at least technically, the best anesthetic next, if you look at the, the category Bs, would be Prilocaine, Citinest. Citinest is category B. It's available plain. So it actually has the combination we're looking for, but the problem is clinicians are often skittish with Prilocaine because of the potential for causing methemoglobinemia. And in pregnancy, when we have 2 lives at stake, not one, which is bad enough, more people will not go with the carbocaine. But technically, carbocaine is category C. Does it really matter? At the end of the day, we pretty much use them interchangeably.
Okay, now that you've confused me considerably on that, let me ask you this then. I'm going to switch subjects, and I want to talk about a subject that's really relevant today, and we're going to get to COVID in the next 2 subjects. I want to talk about pot, cannabis. It's been legalized, and there are some now medical issues coming around. And openly, when you ask if a patient smokes today in your medical history, you really have to ask both questions. And again, I'm not judging, the last person to judge, but could we touch on maybe a few key things that doctors, dentists should be looking at in regards to cannabis?
Absolutely. There's 2 things I always focus on when it comes to patients who use cannabis. The first is keeping in mind that while many people believe smoking cannabis is supposed to mellow you, make you calm, and reduce anxiety and fear, remember that use of cannabis also has a sympathomimetic effect. So basically, it raises the heart rate and it raises the blood pressure. Now, again, that's kind of counterintuitive when you think about it,
Right.
because isn't it supposed to mellow you out? So the other problem is patients who use cannabis are more resistant to the effects of local anesthetics. So you sort of paint yourself into a corner because in one respect, you know they're resistant, so you want to use more anesthetic and more epinephrine to make sure they get profound anesthesia, but you're giving more anesthetic and more epinephrine to a patient who, by their very use of cannabis, is already tachycardic and hypertensive. So it becomes a bit of a dilemma for us, absolutely.
So wait. This is really informative. Okay, so you got a pot smoker in your office, and so rule of thumb would be if you know they're a pot smoker, and I would say then mandatorily the takeaway on this is a lot of offices don't do mandatory blood pressure taking before a procedure. You would absolutely say, Lou, take a blood pressure on every marijuana smoker. Yes or no?
Every marijuana user, every time. There is no exception.
Okay.
I can't say it enough.
Okay, so that's a great takeaway. Now, let me ask you this, Tom, because I've also been reading that patients on other drugs outside of marijuana also are often really difficult to get numb, or they go right through it. In other words, they're numb and 20 minutes later they're not numb. And as a dentist, it just pisses me off. I know it doesn't piss anybody else off, but you're in the middle of prepping 19 or an arch and all of a sudden they're not numb and you swore they were numb and you go, you have to be numb, and they're not numb anymore. So does the drug interactions with getting people numb, it's a real thing, isn't it?
Well, it is. I mean, there's two things to be concerned with there. One is the fact that the patient who uses stimulants, either methamphetamine or cocaine heavily, are more likely to be resistant to the effects of anesthetics because their neuronal membranes are used to the effects of anesthetic agents, because anesthetic agents act like stimulants in that respect. So especially methamphetamine and cocaine. And we all know that cocaine was the first anesthetic used in dentistry. That's when dentistry was cool, if you can remember back those days.
Right, so, very cool. So yeah, I definitely remember those days, yeah.
So honestly, yeah, there's and don't forget redheads. They're difficult to anesthetize too. Let's not leave them out. And that kind of is a good segue, Lou, into the second point I wanted to make about cannabis. And thank you, because the other thing that people don't realize about cannabis is cannabis use causes immunosuppression. And so that means patients who are they're more likely to become infected, especially with HPV. And we all know what that could lead to, oral cancer. So
wait a second. This is huge to me. And this is nothing we prep for. So marijuana users, are categorically or overall immunosuppressed. And we've also learned in the literature that HPV with white male smokers is also prevalent. So HPV, marijuana users, also then we should be looking when we're doing our oral cancer exams really specifically on those patients also. It's another great takeaway, correct, Tom?
Absolutely. When you think about how people consume cannabis, they either smoke it or they vape it, and both of those have been shown to have enough, active and ready carcinogens already in the smoke. So it's just, the multiplying effect for sure.
So just work with me on this. Not vaping, we'll get to vaping, but smoking marijuana, I get the warmth, I get all that. Why are they more HPV prone? Is that just because of the lowered immunosuppression? Well, just walk me through that, just so I get it, so our viewers can.
Sure, there's two reasons why. One is because, we all have endocannabinoids in our body. We make cannabinoids. The phytocannabinoids, which are the plant-based ones, like from marijuana, stimulate receptors in our body. They stimulate the CB2 receptors. The CB2 receptors cause immunosuppression. So that's one direct way. The indirect way is that a lot of vapors share vaping devices. So when they share vaping devices, there's cross-contamination as well.
So now we get into vaping, and there's some real issues with vaping. So I'll start it. So there's a Professor Kumars who did, and I'm really always into perio, and she did, I believe it's a she showed that vapors, whether with nicotine or not, marijuana or not, have a much higher prevalence for perio and the environment to create periodontal disease. You then also just recently put on social media about vaping and COVID. Let's touch on that then on our next quick subject, vaping and COVID. Tom?
Right, very good, sir. So, the thought process behind this recent study that was published was, do vapors have an increased risk of COVID-19 infection? And they were really focused on adolescents and young adults because those are the people that tend to vape more than other traditional vapors. So what did they find? They found that vapors were 5 to 7 times more likely to get COVID-19 infection than non-vapors. Now, of course, the question was, how did you know they were infected with COVID-19?
Right.
And the answer was because vapors have symptoms that resemble COVID-19. The relentless cough and that sort of upper respiratory sound like infection.
Yep.
So they were tested more than other people because they were thought to have COVID-19.
So, Tom, another takeaway. We're good with takeaways on this. I have a really huge screening process about COVID, trying to screen out COVID patients. Last week, we found a patient with an oxygen saturation 2 weeks ago of like in the 60s, sent him to his physician immediately. Wow, agreed.
Wow.
But let's do a takeaway on this. I would be asking patients then, let's say they're under 40. I don't have a lot of patients over 40 who vape. I really don't. And if they're vaping marijuana, they're vaping marijuana. I get it. But traditionally, it's the younger population that's vaping. And I think I got to figure this out. But if I put on my medical history now, on my COVID history, are you vaping? That's another higher risk factor just to know before they come into your office. Agree?
Agreed. And this study was just on vaping, tobacco, nicotine, and smoking, and had nothing to do with cannabis. So cannabis, as you know, is immunosuppressive, as we just discussed. So that sort of, in my mind, increases the risk.
Oh my God. What we're covering in just 10 minutes is, so we're talking vaping, pure tobacco, or even not whatever, or nicotine or not, whatever they're vaping. I don't get the whole thing, to be honest with you. Okay, but if they're vaping cannabis, it puts them right back into HPV risk or oral cancer risk, immunosuppression, and now COVID. Great combination to be doing for recreation. Okay, yeah, that's great. So more stuff to be concerned about with our patients. I want to touch on one more thing in COVID, and then they're just going to have to come and watch you Tuesday night on September 15th or December 4th. I can't promote you enough. Okay. Because I'm learning as I do this. Okay. So I want to talk about COVID and ibuprofen. You're the pharmacist. Ibuprofen. There's been a lot said on it, so this is a two-part question. Talk to me about ibuprofen and COVID, and what if a patient's asymptomatic and you're prescribing ibuprofen? Go with it. Tell me what we do.
Absolutely. So right in the middle of the beginning of the pandemic, there was this surge of information and misinformation about ibuprofen use in patients who had COVID, because the French health minister came out and said he believed that patients who used ibuprofen to treat their symptoms were more likely to die of COVID. And so the World Health Organization backed him up and said, yeah, we believe that as well. Okay, well, it took a weekend, and then every other three-letter agency in the U.S. government, FDA, the CDC and the NIH said, no, that's not the way it works. There's no real hard data to back that up. And eventually, even the World Health Organization came around and said, yeah, you're right. But at that point, the damage was done. The public's confidence in ibuprofen waned completely, and acetaminophen, Tylenol, became toilet paper. You couldn't find it anywhere. It was gone off the shelves.
I remember, yeah. Yeah.
So the problem was now I had lots of people seeking me out saying, hey, you're Mr. Ibuprofen. Whenever you've lectured on this in the past, webinars, seminars, you're always talking about using ibuprofen to treat dental pain. Now what? If I got a patient who I'm not sure has COVID because they may
Right.
be asymptomatic, should I use ibuprofen to treat their dental pain? And the answer is yes, because both, all the agencies I just discussed, plus everybody in practice has already pretty much figured out that that's not true, that patients don't die faster or die more likely because they're taking ibuprofen to treat their symptoms. Despite
Right.
all the people who have their podcasts in their garage and their basements, no, it's not true.
So it's not true. We're dispelling it from the
Right.
World Health Organization, who's basically told people not to go to the dentist, where I feel it's the safest place to be. I feel safer in my office than I do walking anywhere, but that's another story. I won't get political. Okay, so it's safe to use. Tom, let's
Yes.
close on a hot new product then. A hot new product, and it's not a dental product, but I believe, did Advil just come out with a dual action pill? Did they?
Yeah,
Or did they not?
they did indeed, and I have to tell you, I feel bad for them in a way because they launched on March 1st, right dead smack at the height of the the whole thing with COVID. So even though the product was actually approved and ready to launch, it didn't actually come out until I think earlier, a couple of weeks ago, later in the month of July. I'm not even sure it's
Okay.
on the shelves
Wow.
yet. It's in production. So what
Okay.
is Advil dual action? Advil dual action is one of the first times, I think there may be one other time in the past, I'm not sure, but in recent history, one of the first times we have a dual action tablet where we have both ibuprofen and acetaminophen in the same tablet. So this received a lot of fanfare, especially from people who follow me on the internet and on my web page
Right.
and on my social media pages, because they knew I've been extolling the virtues of ibuprofen and acetaminophen combinations for all these years. And so they said, hey, look, we finally got a product that combines two ingredients in one tablet. This has got to be great for dentistry. And while I agreed on the surface and said, yes, it's good that we have a combination product, ibuprofen and acetaminophen in one tablet, it's going to make our lives easier. It's unfortunate because the combination of the two ingredients isn't well tuned for dentistry. Each tablet contains 125 milligrams of ibuprofen and 250 milligrams of acetaminophen. Okay, if you've heard me speak before, you know I say the sweet spot is somewhere between 400 and 600 milligrams of ibuprofen.
Absolutely.
So that would mean,
Yep.
right? All right. So you'd need
Yep.
4 tablets, okay? 4 of these tablets to get to the
Yep.
ibuprofen dose you're looking for. But
Right.
when you take 4 tablets, now that's 250 milligrams of acetaminophen in each one. That's 1,000 milligrams of acetaminophen. Okay, still not bad. But if you then took it 4 times a day, which what we recommend for that dose of ibuprofen, now you're getting 4,000 milligrams of acetaminophen. And that,
Right.
unfortunately, is right at the upper limit. And I'll tell you something, Lou, not many people know this. Here's another takeaway for you. The manufacturer of Tylenol says their maximum daily dose is 3,000 milligrams, even though the FDA says for acetaminophen, it's 4,000 milligrams. And the reason for that is the manufacturer of Tylenol says there's so many other sources of acetaminophen out there that people can take Tylenol PM, Tylenol cold and sinus, NyQuil, Dayquil, Excedrin, and get so much extra Tylenol that if they're already at the upper limit of 4,000, there's no wiggle room. So that's why I think Advil Dual Action is a great product. The other real nail in the coffin is, the manufacturer says you're not supposed to take more than 6 tablets a day. And so we're obviously way over that if we try to use it for dentistry.
So Tom, then I'm going to close on this. In what you talk about, if we're taking 400 to 600 milligrams of ibuprofen, let's call it QID. What are you then bumping it with Tylenol? Is it at the same time? Is it 2 hours later? And how much Tylenol?
I think it should be taken together. The true synergistic effect of ibuprofen and acetaminophen occurs when you take it together. I'm an advocate of taking 2,000 milligrams, 500 milligrams, along with the 600 milligrams or so of ibuprofen 4 times a day. The reason I go with 2,000.
500. Okay. Yeah.
Right. 500, 4 times a day, along with the Advil. And the reason I say 2,000 is because we have to leave room for the fact that we may want to prescribe an opioid analgesic, and all opioid analgesics we use in dentistry contain acetaminophen. So that in itself could easily push another 1,000 right there, and then we're right up to the 3,000 milligram dose.
Wow. Okay, Tom, I got to tell you, if people don't turn in on September 15th, good luck to them. This has been great. I can't wait to learn more. So glad you're a part of Catapult. You're such a good guy. Thanks for sharing and teaching. I really, really mean it.
So are you, my friend. Thank you.
Any final
You're a leader
words,
in
Tom?
this. Yeah, I wanted to say you're a leader in this profession, Lou, and thank God for leaders like you, because in times like this, we seek out people like you. So thank you for all you do for this profession.
Thank you, pal. See you soon. So let me be clear. We want to hear from you. We want to hear your questions. So what we want you to do is we want you to go to education@midwaydental.com. Shoot us your questions. We'll go right to the experts. I know I'm not the expert, so let's go ask the experts what we should be doing as our next step next week, the week after, and thereafter. I look forward to hearing from you.